All right, so good evening, everyone. Thanks so much for coming along this evening to our heart failure education and awareness event with the Irish Heart Foundation. So my name's Helen Gaynor and I'm with the Patient Support Services. And just a couple of housekeeping items before we start. So the toilets are straight out the main door, just across the lobby. There's fire exits on either side and one over there. The event is live streamed, so it'll be videoed, just to let you know. If you wouldn't mind turning off your phones, that would be great. What else? We will also have a photographer present, so if you would rather not have your photo taken, just let one of the staff know. So the IHF staff, we're all wearing one of these, okay? So look, I'm just going to introduce our panel of speakers all together. So first of all, just to say that we're absolutely delighted with the panel of speakers that we have here this evening. So first up is Professor Emer Joyce. And Professor Joyce is a consultant heart function and transplant cardiologist in the Mater Hospital. And she's going to talk about the diagnosis, treatment, and function of heart failure. After Professor Joyce, we will hear from Dr. Sinead Mulhern. And Dr. Mulhern is a principal psychologist in the Mater Hospital as well, and she will talk about the psychological and emotional effects of living with heart failure. After Dr. Mulhern, we'll then hear from Karen Maclaughlin. So we're delighted to have Karen here tonight. Karen has been living well with heart failure for the last number of years, and she will talk about the patient perspective and how she's been getting on since her diagnosis. Next, we have Pauline O'Shea, and Pauline is the Advocacy Manager with the Irish Heart Foundation. And Pauline will talk about finding the patient's voice, as well as the advocacy initiatives that we are running at the moment in the IHF. And then lastly, we have Orna O'Brien, and Orna is our Senior Dietitian with the Irish Heart Foundation, and she will talk about the dietary management of heart failure. So without further ado, I'm going to ask Professor Joyce to come up now. Thanks very much.
Thanks, Helen, and thanks to the Irish Heart Foundation for putting on this wonderful event. I think it's going to be the first of many. The last time, I don't know if anyone is in the room, was here. We were in, I think, a dark night in November in 2019, so it's been a long time since we had one of these events. So it's great to see everybody here and those of us joining us online. So I'm going to talk about really what you and your caregivers and your family need to know in terms of living with heart failure, living with the diagnosis of heart failure, and just go through, I've sort of designed this talk around how I would talk to somebody who's just been diagnosed with heart failure in the clinic, and when they come back and see me, and just exactly sort of explaining causes, explaining why all of those medications, why the medications are important. I'm going to start with the name, and if you notice, Helen introduced me as a heart function cardiologist. That is deliberate, and that is a growing movement that we want, that's happening internationally, and that ultimately we want to see happening in Ireland, to take the failure out of the name. The last thing I want to be introduced as is somebody with failure in the name. And I want everyone in the room ultimately to feel that same way, that there's no failure in the diagnosis that you have. There's no failure in the management therapies that we have, the diagnostic strategies. It's actually the opposite. There's actually a whole lot of success going on. It's taken a while being in this specialty for some time, but it's really, especially going forward, an area of amazing success. So just hopefully going forward, we'll be able to talk about heart dysfunction, heart inefficiency, heart insufficiency. But first of all, we have to get the awareness of heart failure itself, and then we'll work on changing that term. But certainly moving forward, that's what I call myself. So heart failure doesn't mean that your heart is failing. It means that your heart is suboptimally working at its job for whatever cause, which we'll discuss. So because of whatever has affected it, and there are multiple causes, it's not able to pump quite enough blood at quite the pressure or the flow or the rate that it needs to meet the demands of your body. So really, you can see that heart inefficiency or heart dysfunction is probably a better term. It does not mean that your heart has stopped working. How common is it in Ireland? I sort of use this number, but straight away hate using it because there are a lot more than 90,000 people living in Ireland with heart failure. This is just older conservative data that we have from 2012. It's likely to be a much higher number because of the growth in the risk factors for heart failure, but also the success in treating a lot of the conditions that lead to heart failure, where in the past people wouldn't have survived with those other cardiac conditions, but now they're surviving, living longer and living well. So it's likely to be well over 90,000. So there's a lot of you out there. Probably around 10,000 new diagnoses per year. And about 5% of our group, this is from data that we've done since I've come back to Ireland, have markers of a more advanced heart failure syndrome. But overall, that number is likely to be more. As I've said in the introduction, probably the main thing that I want you to take away is that this is really the golden age for heart failure, for us working in the area, as well as hopefully that you will see, if you have to have this diagnosis, that it is a better time to have it. And that's because of improved tools for diagnosis, for risk stratification, genetic therapies, PET scans, MRI scans, a whole lot more in terms of looking into the causes of heart failure when you first present. There's been massive developments in medical therapy, really, really huge developments, and they're ongoing. Every conference that we're going to now twice a year, the heart failure trials are sort of top line and the most exciting, and there's most people in the room for the heart failure trials. And when you see that, you get excited because there's even more therapies coming online, improving quality of life, improving survival, improving all the things. And also sort of my other side of line is things at a more advanced stage. And thankfully, there's huge amounts of things coming down there as well. New pumps, better pumps, things that better ways of taking care of transplant patients, that if you do end up becoming advanced and being eligible, that there are also more options there. So overall, a golden age. Just to review the symptoms of heart failure, I think that's important. I think probably preaching to the converted in this room, but it's not just shortness of breath and swelling. They are often prominent symptoms of heart failure, but important to know, we often ask in clinics, you'll hear us asking about how many pillows do you use. That's a symptom called orthopnea. If you're becoming congested with heart failure, if fluid is building up, you'll often find that you need to raise the head of the bed at night, increase the number of pillows. When it gets more severe, you might start coughing at night. Be aware if you have no other symptoms of a chest infection or COVID or something, you suddenly start coughing at night. Look to your ankles, your belly, your weighing scale. Are there other symptoms? Just be aware that cough is often a symptom of heart failure, particularly nighttime cough. Often talk to people and say, people often come to hospital with an exacerbation of heart failure and hospitalization with their worst symptom. And what we really need to work back, worst symptom is often waking up in the middle of the night short of breath, 10 kilos of fluid weight. What we need to do is say, well, what was your first symptom? Can you look back and see what was your first symptom? And then can we act earlier where you won't end up having to ideally come into hospital? That's where we're often so obsessed with the weighing scales and heart failure, because weight is one of those things that can go up when you still feel fine. Also be aware, though, particularly younger patients, particularly maybe people who've had a new diagnosis of, they're often what we would call GI as medics and nurses, but more sort of the gut symptoms of heart failure. Swelling of the belly, being a bit nauseous, being a bit off your food, maybe vomiting. As some patients put on fluid weight in their belly, in their guts, and that can get quite distended. Sometimes it might not be noticeable, and you might just notice, you're not able to finish a meal that you would finish before. So just kind of be aware. Fatigue, again, is multifactorial. We'll talk a little bit about that if we have time, but it can be a manifestation of a particular type of heart failure. Abdominal pain, again, just being aware that it's not necessarily just the top line symptoms. There can be more unusual symptoms. What are the causes? Number one cause is what I call cardiovascular risk factors. Number one cause in cardiovascular risk factors is high blood pressure. So by far and away, either the primary cause or sort of the co-contributor, the co-conspirator, co-culprit in many, many cases. And when you're diagnosed with heart failure, we really become obsessed with getting that blood pressure down. And not just okay, or oh, it was grand, or sure, one value was up. It has to be scrupulously, really meticulously down every single visit. And we'll talk a little bit about where we want to get that down. But that's because it's often, even if it's not the primary cause and you have something else, it's often a driver of the syndrome. Being overweight, having diabetes, these are all things that can stiffen the heart outside of, and that can cause the heart failure itself. They might be present on their own, or they might be present with coronary artery disease. That's coronary artery disease describes having narrowing or blockages in those arteries that supply the heart. You might have a stent, have had a bypass, or have had an angiogram that shows disease that we're managing with medicines, aspirin, cholesterol medications. That's a frequently common cause, particularly if you've had a heart attack before. That can often reduce that muscle function and cause or lead you to be at risk of the heart failure syndrome. And then quite a common, other common group of causes is what we call cardiomyopathies. And I think this term can be confusing, but cardiomyopathies really describe a really broad term of conditions that can be caused by coronary artery disease, ischemic cardiomyopathy we call that, or can be caused by a whole lot of other things. We call that non-ischemic, non-coronary artery disease type cardiomyopathy. Very common in this the most common would be genetic causes, and we're increasingly doing genetic testing and finding a gene that's abnormal in the family. Alcohol, drugs, they might be recreational drugs, they might be prescribed drugs. If you've had chemotherapy, there are certain chemotherapies that we know can lead to cardiomyopathies. Other medical conditions, viral infections, you'll have heard the term myocarditis is a common cause. Other heart problems, very common. You may have had history of arrhythmias, atrial fibrillation, atrial flutter. That might have been treated or cardioverted or ablations, but over time maybe has led to, maybe together with hypertension or other risk factors. Valvular heart conditions, or obviously congenital heart disease, having had the condition from birth. How do we diagnose it? Most importantly is the history and exam. A lot of patients, I would say 90%, we can diagnose just by having a chat and seeing them in the consultation room, doing the examination, talking about those symptoms that we talked about, doing the examination. We'll be looking at your neck, looking at your jugular venous pulsation. People think I'm a vampire. I don't know if any of the patients who've been to my clinic are here, but again, we're looking at this. That's a really good barometer of what fluid is in the system. So that's why we're so obsessed with the neck. We'll be listening to the lungs, listening to the heart, and checking the abdomen. We do a blood test. We do a lot of blood tests, including kidney function and depending on various medications. We also do a blood test called the BNP, or the NT-proBNP, beta-natriuretic peptide. And that's a very useful medication. It's not the be-all and end-all, pardon the pun, but it is useful for us to sort of see how you're getting on, to see once we start someone on medications, is that number coming down? We want it to be below a certain point. If we see it going up, we know we need to change something. If we see it going down, we're in the right direction. So don't be afraid to ask, about these numbers. What's my BNP? Ask your nurse practitioners, your doctors in the clinic. 12-lead ECG, we're looking for signs of old heart attack, for arrhythmias, for other new problems. And then the echo is kind of cornerstone. And the reason the echo is cornerstone is that we're looking at what we call as ejection fraction. Again, probably a term you've heard. You might not be too you might be going, God, what do they mean by ejection fraction? It's basically just a surrogate measure. It's not a direct measure of how the heart is pumping. We'd have to, open your chest and do an experimental study to do that. But it's what we use. We use it every single day to talk to each other and to yourselves about how well your heart is pumping. It's becoming less and less important as time is going on, because we're recognizing that regardless of your ejection fraction, you can still have quite a significant heart failure syndrome. It used to be that it was only the people who had a lower ejection fraction that the trials show responded to the therapies. And thankfully, we've such new therapies now, that's changing. And people who also have a preserved ejection fraction are also shown to benefit from these therapies. So what is it? It just describes the volume it's a volume measure, the volume of blood in the heart, the volume of blood pumped out per heartbeat versus the volume of blood in the heart. It's a percentage. It's never going to be 100%, because if you imagine like a plastic bag that you want to hold, that you want to keep some tension in it or tensile function. If you take 100% of blood out, it's going to shrivel up. You don't want that to happen to the heart. You want to keep it tense. So around about 55% is normal. When we're talking about low ejection fraction, we're generally talking about anything less than 55, but sort of the classic reduced ejection fraction is less than 35%. The general categorization that we've used for years has been, well, you're either HEF-REF or HEF-PEF, as I've sort of mentioned already, either reduced ejection fraction, that sort of weak, baggy heart. These are usually the cardiomyopathies, maybe alcohol, genetic causes, having had a heart attack, versus the more stiff or thickened heart. That's things like, most commonly, blood pressure, getting older, diabetes, maybe overweight, amyloid, and other conditions like that. So that was kind of the classic discriminator. They've since added a couple of other categories, just in case you hear us talking about them. We now say pure reduced is less than 40, mildly reduced between 40 to 50, preserved is over 50. We can also talk about improved. So it's important, but not the be-all and end-all. So most importantly, lastly, what can be done? Is there any treatment? And as I've already alluded to, so much can be done, multiple treatments. Everyone with a diagnosis of heart failure will obviously, if they consent to do so and want to do so, should be on medications. And everybody will need to undergo lifestyle changes. They are the key, those two things, and you'll hear more about the lifestyle changes later on. Some people, implantable devices, defibrillators. Some people might need other surgeries, valve surgeries, TAVIs, different types of procedures. But the cornerstone are the medications and the lifestyle changes. And the goal is to improve function, keep people out of the hospital, obviously improve the big picture stuff like living longer, but also very importantly to improve quality of life. Why do you have to take all these medications? And that can be difficult to sort of understand, especially maybe if you were diagnosed feeling not too bad, or maybe you're coming back to clinic, you were on all these medications and now you're like, well, I feel fine now and I think my ejection fraction is improving, or why is it that you have to take these medications? And just to understand a little bit, the science bit, I think is helpful. This was more of a science diagram that I've just sort of adapted, so hopefully it's helpful. So when you have that initial insult, whatever it is, so your heart attack, your cardiomyopathy, your high blood pressure, whatever it is, those causes that we talked about, when you reach a certain threshold, or when they affect the heart, there's this insult to the heart muscle. What's the heart? It's a pump to the organs. So what happens? There's decreased blood flow to the organs. If that was left there, everything would probably, provided it wasn't maybe a massive heart attack or a massive insult, things would probably settle down. And you could go about things. The problem is it's not left there. The body goes into stress and goes, wow, the blood flow is down, cardiac output is down, this is a stressful situation. And it goes into overdrive. And that is the problem with heart failure. And the role of the medications is to stop that overdrive. Because what does that overdrive do? God, the kidneys go, geez, we don't have enough blood, we better hold on to salt and water. We don't have enough blood, we better raise the blood pressure. What else will we do? God, if we have a higher heart rate, we'll pump the heart more. But of course, pumping the heart more will put more strain on the heart. So what we're trying to do with all the different medications that we have is shut off those responses. They have other benefits. We're also trying to lower blood pressure. The same medications lower blood pressure, and we do want to lower the pressure on the heart. And some people say, well, my pressure's 120, why do you still want to lower it? And I like to use the analogy of, if you're trying to blow up an airbed, or you're trying to pump something through, or blow up a balloon, you want to try, and liquid always wants to go from high to low pressure. So when we talk about blood pressure, we talk about the pressure and the volume of blood after the heart. So you can imagine that a heart that's sick, for whatever reason, that's tired, doesn't want to pump to high pressure. It wants to pump to lower pressure. So if we lower that column, that pressure in the aorta, the column of blood, then the heart can say, ooh, good, okay, less work to do. More time spent regenerating, recovering, switching off these mechanisms. So it's a targeted, so we really want to go as low as we can possibly go. That's why we keep progressively increasing the medications, as well as shoving off all of those things. So you might hear us talk about the 4 pillars of medical therapy. There's a new pillar added, and there's changes, and this is what's changed. And there's an ARNI-type medication. I probably won't talk about drug names here, but that's going to be one of the cornerstones, RNase inhibitor medication, or an A or B. There's a beta blocker. There's a mineralocorticoid receptor antagonist, spironolactone or eplerenone, and there's an SGLT2 inhibitor, easier to say it that way, that are the new kids on the block that have also been shown to be useful. And we know there's some science numbers here, because I think it's useful to see, especially when you're the ones having to take these medications, which is not easy. But taking all these 4 has shown massive numbers in risk reduction. Trust me in that there's very few therapies that show these sort of risk reduction numbers. For example, even a statin, well, I don't want to go against your other medications, which are very important, but even things like aspirin or cholesterol medications, they have much less risk reduction, and they're still really, really important. So these medications, such a huge risk reduction. So we call it, you might see GDMT mentioned, that's just goal-directed medical therapy, and that's telling ourselves we need to get the goal-directed medical therapy on board. We need to get all 4 medications on board as tolerated. Now, you might think, God, I'm not on all 4, I'm only on this version. Different people have different profiles. So obviously we always have to individualize that there's maybe different reasons that people will be on, maybe, that may not be able to be on one of the medications, but certainly discuss it with your local heart failure clinic. Obviously, many patients will need diuretics. Other blood pressure medicines, if it's not controlled, remember we need to get that blood pressure down. If you're diabetic, you may need other medications. You have AFib, you may need medications for that, blood thinner, NOACs, apixaban, different types of medications. So all for a very good reason. We've sort of covered this, just that question that I often get, God, I feel fine. Why are you going up on the medications? Because in the trials, the higher the medications, the more you switched off that overdrive, the more you lowered the pressure and got more time for that heart to recover. Here about fatigue. Fatigue is multifactorial. I mean, we're all tired, but particularly as it's hard to delineate in heart failure patients. And certainly the condition, especially if you've established heart failure, the condition is probably a huge amount of that. Can some of it be medications? Absolutely. But it's really important that we sort of try and treat everything else, the anemia, the sleep apnea, the lifestyle, get the sleep stuff right, get your exercise, all your lifestyle things that can affect sleep, which is huge. Your fitness level prior to last resort really to reduce the medications. And there's other things you kind of know if it's the medications, if when you're putting them, when you're first going up on them, you can sort of tell that you feel it, and you can do different things like slowing down the dosage, changing the dosage to nighttime, little tricks that usually over time, over a week or two, these things resolve. So very high threshold to reduce medications. So last couple of slides. Do I need a defibrillator? You might need a defibrillator. Who are the people who need a defibrillator? This is where the EF comes into it, because we know that those who have the reduced ejection fraction, less than 35%, are more at risk of just suddenly firing off a life-threatening heart rhythm that a defibrillator can treat instantly. Or if your EF doesn't improve on meds, even if you're feeling fine, that could be an indication. There's certain other heart failure causes less common that we see, like sarcoid, like genetic, some other things that you might need defibrillators for. So I think we talked about that. The guidelines, we want the blood pressure definitely less than 130/80, ideally a lot less than 130/80, because we really want to get those medications on board. And so really the target's generally 90 to 100, depending on age, frailty, other factors, really to get as low as possible. So will you need a heart transplant? Hopefully there's no too squeamish in the room. Most people will not, thankfully, need a heart transplant. It's a rare therapy. If you do end up being in the advanced category and be eligible for it, it's something that is an amazing therapy. It's a life-giving therapy. It's a miracle therapy, and still the gold standard for certain types of heart failure, but hopefully vast majority will not need it. We're also thankfully seeing a resurgence an increasing research and development in heart pumps, or LVADs. This was 2009 in the Wall Street Journal. They've really come on since then. And they're an option, and they can be suitable for patients with really severe heart failure who wouldn't be suitable for transplant. So that's where they're really beneficial, that we have potentially something with us. And that's why I suppose I should explain this photo, because I think I put it at the start and people were like, what? I just thought it was, I think a lot of times with the diagnosis like this, I find that patients in my room are in their heads, worrying about things very appropriately, because it's, as I said, a big term, a big diagnosis. And I thought it really encapsulated that you're worrying about your heart condition, you're in your head about it. But hopefully by coming to meetings like this and educating and asking questions, I wanted to deliberately give information here that you can go back to your clinics and your heart failure clinics and ask questions. What's my BNP? What's my ejection fraction? There's these 4 pillars of medications. Am I on them? If not, why? And really just to seek out that care. And I think I'll end there.
Okay, move on. Am I going in the right direction? I'm going backwards here, am I?
That's it, yeah.
Just add in some bits here.
There we are.
Yeah. Okay, hi everybody. I'm Sinead Mulhern. I'm a psychologist who works in the cardiac rehab program in the Mater, and I'm here to talk about the emotional and psychological impact of living with heart failure. So the people that I work with heart failure have come through the cardiac rehab program. So I know there's lots of different types of experience with heart failure, so this will hopefully be a benefit to people depending on where they're at in their stage of their journey. So just to quickly overview, we'll talk about the psychological impact, and I suppose the interplay between the physical and the emotional. I suppose we're a body with emotion, and I suppose the experience of that. We're going to quickly look at, we've 15 minutes, so I'm probably over-ambitiously had too many slides, but hopefully I'll be able to go through it in a way that you can understand. So look at maybe some healthy coping strategies and exits from patterns of behaviour. And then mindfulness, and on our Mater webpage we have some mindfulness exercises that I think people often find very helpful. Okay, so we've gone through, and thank you, Professor Joyce, for that great talk there, and we are all aware of the physical demands that you're experiencing in terms of living with heart failure. I suppose just to outline a little bit in terms of, I suppose, all that we're dealing with in terms of medical interventions, surgery, the challenges of day-to-day life with living with the, fluid restrictions, appointments, the medical experience that you have, which are all, essential and extremely valuable, but can be quite demanding. And in terms of the physical exhaustion that people feel, pacing that's required. Sorry.
We're missing a lot of what you're saying.
Oh, sorry, am I flying
the
to?
microphone could be brought a little
Sure.
closer to you.
Sorry. Okay. Yeah. Sorry. I'll come
Thank you
through.
very
No, you're okay. No, that's important. Okay, so just really kind of outlining some of the physical demands, and I think you're all very aware of what they are, but in terms of kind of sleep, the loss of role, the change in terms of our capacity, our identity, work, family context, and I suppose just the chronic nature of it and the difficulty that can bring. And I suppose sometimes the isolation, lack of understanding, or sense of disconnection. So I think that's some of the physical landscape. In terms of the emotional, I'm sorry, I'm devil for putting in too much information in slides, but really the emotional impact, which again I think people are very aware of, but I think it's worth naming or just kind of acknowledging, I suppose, all that we're holding in relation to the emotional impact of chronic kind of heart condition like that. The roller coaster effect, I suppose, that can lead to overwhelm. There's a lot of fear, worry, future uncertainty, a lot of maybe trauma or shock. There can be an immediate impact that suddenly you're thrown into this situation and having to deal with it. There can be a lot of trauma in relation to the experience of having gone into hospital, ICU, etc. The grief, I suppose we have plans, we all have plans as to how our life is going to be and what that's like when that's derailed, and most of us are coping the best we can with the cards we're dealt, but there is a grief and a loss associated with that sometimes we don't have as much room for. The distress, I suppose, the repeated nature of it, even if you're doing everything right and you're doing what you're told and there's still difficulty, and the distress that we feel with that, at times this can be despairing or overwhelming. A lack of control over the situation, frustration, disappointment, and gratitude at the same time, that we have a lot of interventions that we can benefit from, but also the frustration and the difficulty with it. A lot of resilience and stamina required for the ongoing kind of nature of the challenges, and how to accept, I suppose, our vulnerability. We're imperfect, we're mortal, and some of us are much more aware of that than others on a day-to-day basis, and how do we live with that and live in an okay way with that. And often the emotions can bubble up after the event. So we can be doing well medically, physically, surgically, getting good feedback, but actually sometimes when it's safer, people then notice, actually, I'm getting a bit derailed now, and why is that? Which is very normal in terms of experiencing that when things are safer. So I suppose that's just to explain, there's an emotional context, there's the physical context and symptoms, and then there's the interpretations that we put on that experience. What does this mean? What's going to happen next? Guilt and blame, responsibility, etc. So we can have lots of different thoughts about the situation, which then further impact how we emotionally respond to it and what we might choose to do next. So I suppose psychological health can either help or inhibit our physical recovery. And that's where I suppose the psychology comes into it in a way. And people often wonder, well, is psychology more of a kind of a therapy in the community? But actually within the hospital context, people are dealing with an awful lot of experience. And I think you guys know this more than anybody, but in terms of, I suppose, the kind of need for support, it can really kind of inhibit people's adherence to their treatment program. It can inhibit, I suppose, our kind of recovery process and our ability to engage, or it can really enhance if we're doing well. Anxiety and depression are very common, and insomnia, difficulties in terms of people with general kind of cardiology issues, the trauma that we've mentioned before in terms of, certain people might be more at risk of developing things like PTSD or trauma post-ICU, depending on what people have experienced, which might, just to say a little bit about what that is, kind of post-discharge, people sometimes can have experiences of flashbacks or very strong symptoms of anxiety, palpitations, nausea, sweating, nightmares, and people think that they're going mad. And I suppose just to say that there can be, this can be quite a common experience for people post-ICU discharge. And so important, and that there is a recovery process and healing that can happen with that. So things like mood, stress impact on our sleep, on our self-care. So I suppose that mind-body dualism, where if I'm feeling well, I'm more likely to take care of myself and to try and do things well. I suppose the impact of long hospital admission can have on our mood, and I suppose our optimism about the future. If we're feeling down, we have a kind of a bias towards looking at things in a negative way, which becomes a bit of a circular loop then, and we miss some of the fuller picture when we're feeling a bit overwhelmed. And I suppose I mentioned before just that idea of our vulnerability, and how do we accept that? How does anybody accept that? So there's a busy slide, basically just alluding to what we've talked about there in terms of our kind of negative psychological health will have an impact on the choices that we make. Positive psychological health, we're more likely to do things that will be of benefit physically to our body, and to make changes or choices that will bode well for us. It sounds a bit simplistic, but you can understand where I'm coming from. In terms of psychological well-being, so kind of factors that would promote that or would reflect kind of psychological well-being would include things like autonomy, where I have choice over what happens, mastery over my environment, opportunities for growth, I can meet challenges and learn from them, positive relationships, connection, sense of purpose or meaning, self-acceptance, and kind of a realistic self-appraisal. So these are all things, if things are going well, I might be ticking some of these boxes, whereas some of the difficulty with health, ill health, and the distress comes from the fact that we have maybe limited choice, there's uncertainty about the future, we might have restriction around our mastery of our environment, we can be overwhelmed by challenges, there might be a disconnection, a sense of loss of role or purpose, and a disconnection, and sometimes kind of a lot of distress or self-criticism. So you can see why, we all know this, and in some ways I'm labouring the point, but I suppose the idea that actually it's massive, some of the things that we're carrying, on top of trying to deal with all of the kind of maybe physical regime, just acknowledging actually how I'm feeling on a given day might impact on what I do next, and that it's really important to address it if we can, to get support with it, and to look at self-care, that it's a real need. Just because we can't see it doesn't mean that it doesn't exist. So I suppose the mode that we get into when we're under stress or pressure is fight or flight mode. It's a fantastic survival instinct within the human and animal kingdom in terms of we're all hardwired to survive. What's happened with humans is we have this fabulous big brain and we do lots of thinking, which is great. But the problem is that we can think a lot about our difficulty and our danger or potential threat, which means we re-experience that feeling of being under threat or pressure physiologically in the body, as if we are being chased by a tiger or as if we are needing to respond in that kind of high-level threat. And the impact of that on the body is it has cardiovascular impact in terms of kind of adrenaline and our blood pressure and our need. I suppose the physiological response is in order to help us to run away or to fight danger. And it's a huge kind of physiological cost. If we are living in an anxious mode in our mind all the time and having kind of symptoms of anxiety, there's kind of a physical cost to that. Or we become very irritable, so that kind of attack mode, or wanting to get away, wanting to kind of avoid. So they're the two modes that people might be in. So there's, it's really beneficial when there's a real immediate threat or danger to us, when it is a threat that is in our mind that may not be immediate, that's linked to a physical difficulty. We're worried about the future, we're worried about our family, we're worried about all these different things, which are very real, but we may not need that huge physical response in this moment. So we might need a different way of looking at that. So if we're very caught in that type of thinking or anxiety, we need to respond physically in the body and to kind of slow it down and be able to kind of breathe, to be able to manage slightly differently. So I suppose any situation, we think about it, we interpret the situation in some way, we feel it emotionally in the body, we have a body reaction in terms of that fight or flight piece, and then we do something in response. So we might have a worry about a situation, we might feel anxious, we might have anxiety in the body, that kind of flight mode experience, and then we might pull back or withdraw. That's human nature, that's not particular to people with heart difficulties, but we can sometimes not like that feeling or a negative emotion. We can tend to want to push it away. I don't like this, it's not nice, so we want to avoid it. Very normal reaction. However, emotions give us really important information. So if I'm having a lot of negative emotion or a lot of distress in that situation, asking what do I need instead of that automatic urge to kind of push it away or get away from this horrible feeling, which we all do. There's no shame in that, but sometimes we're better approaching it and beginning to kind of ask, what do I need to help myself with this? Our distress is often wise, it's often very real, and it's trying to communicate a need. So we need to sometimes listen to that, and that can be uncomfortable at times. So making some room for self-compassion sounds very glib and easy to do, but actually we really need to do it in order to kind of survive very challenging situations. And if the distress level is interrupting your life to a point of your behaviour, your actions, or what you're doing, it's really important to acknowledge it, and to sometimes we hope that it'll just go away, and if it's possible to get some support with that. So in terms of kind of heart, well, I'm going to start saying heart dysfunction or heart, I'm going to take failure out of the slides, but the thinking might be something along the lines, I can't cope, this is going to be lifelong, everyone else is okay, why does this happen to me? Or what if worry about the future, which might lead to certain types of emotions, anxiety or anger. It might have kind of physiological response in the body, and then we might do something as a result. And I suppose for you to just pick for yourself, what do I tend to think when I'm under pressure? What would be my kind of alarm, or what would somebody else say that, yes, okay, I can see that you're under pressure. What am I saying to myself? What am I feeling in my body? What emotion am I feeling? And what do I tend to do? Because if I can recognize or be aware of how I am, then I've got much more option of responding differently. Otherwise, I'm just reacting, I'm in that kind of fight or flight mode, and I have less choice over what I do next. So just becoming aware, even taking time yourself to think about actually what thoughts, behaviours and feelings do I tend to have when I'm under pressure. And this is important so that we don't push it away, that we can recognise it, and the idea of moving towards something that feels uncomfortable. How do I accept that actually this is a really difficult, challenging situation? Because when I have a situation that's difficult, if I'm adding another layer on top of that in terms of my interpretation of that event, I'm creating more suffering. So it's difficult enough to deal with the situation as it is. If I'm saying this is not okay, I'm a failure in some way, I'm not getting this right, everybody else is better at this than I am, etc. I'm adding another layer, which that bit I have some control over. The initial bit I may not have as much control over. So how I can respond differently. So I might not be able to control the cardiology piece to an extent outside of what I'm recommended to do, but I might be able to respond differently. So I have a choice over my response. Okay, I've mentioned that. So yeah, recognizing my own distress and how I can accept. And by accept, I don't mean that we kind of just suck it up and, you know, get on with it. It's that actually kind of radically accept that this is a very challenging situation for anybody to be in, and how best can I meet my needs to cope with this. So we're facing it rather than, you know, we're not just blindly accepting, we're approaching it as opposed to kind of moving away from it. If I can build awareness of my own personal reactions, observe myself in the moment. So if I'm slowing down, if I have a lot of anxiety, a lot of distress, a lot of overwhelm, if I can take some time to slow it down, I am much more likely to tune in and notice and be aware of myself in the present moment. And then I can make a choice, just that split-second choice of what I might do next. So if I can observe myself in action, I might be able to catch my thoughts. What did I just say to myself that's just sent me into a total slump? Can I challenge it? Can I ask if it's true? Is it really true that I'm a total disaster here, that it's never going to work out, that it's never going to be okay? How helpful is my thinking? Can I let some of it go? So observing how you feel. There's an old adage of, an old Indian analogy of the two wolves, and in terms of which you might, it's just escaping me now, I can't remember what it is, but basically which wolf do I feed? The wolf of anger or the wolf of love, essentially? And the question is, which one wins the fight? The two are fighting, and it's like, well, whichever one you feed. How do you grow this aspect within yourself more, which is a challenge for any of us. And slowing down. So that kind of autopilot, we're all often on autopilot where we react automatically. We're overburdened in our mind and we don't have a space to slow down. So just creating that space. So how do I find healthy exits? Some of it is around challenging unhelpful thoughts. Can I ask, is this unhelpful? Can I notice? Can I name it? Can I challenge some of the critical thoughts that might be there? How might I accept or adapt? Sometimes talking about it or writing it down might help me to process some of it, to get it out of my head. Asking for support often can be quite difficult, but often very needed. How do I regulate my emotions? What are the things that soothe and calm things down for me or ground me? Self-compassion. How do I treat myself like I would a friend? What is a kind thing I might say to myself or a friend in this situation? Often we're very good at compassion for other people. We're sometimes not so good at it for ourselves. We can hold ourselves to a higher bar. The physical care in the body. How do I slow down? Look at sleep, diet, breathing, exercise, yoga, relaxation. And that fight or flight mode that we're in is often we're physically prepped to move and to run. And so sometimes kind of physically moving or allowing the breath to regulate in that way can be one of the most helpful things to do if you have a lot of anxiety. And our behaviour then, how do we look at goals? Things that are, so within all of this, you know, all of us are mortal, all of us are going to die, most of us don't think about it all the time. What is the benefit of thinking about this? What is, you know, this is very overwhelming. It's one of the most threatening things we can think about. And at the same time, if I can accept it in some way, is there a way that I can use this meaningfully to be able to live a better quality of life? So, you know, ultimately we're all here for a short period of time. We don't really know how long that's going to be. And how is it that I can improve my quality of life? What are the things I love to do? Who are the people that I love to be with? What are the things that I can take meaning and value from, that I can create a good quality of life forever long I have? And I'm conscious of the time there now, but this is, I suppose, some of that in terms of, don't want to miss out on things. Yeah. So I suppose, yeah, basically, how do I create a kind of a good quality of life? What are the aspects of my life that need to be supported for me to be able to manage well, in terms of meaning and meaning-centred focus in your life? There's, some of you might be aware of Man's Search for Meaning, Viktor Frankl, that idea that actually we are very purpose, value-led, and how do I create a sense of purpose within my life in whatever way I can. Yeah, so just spending time thinking about what's important to me, and if my ability to relate to it has changed because of my health condition, what's the important kind of underlying piece that I can still connect with, even if that's in a different way. So if I can't play football with my son in the same way that I used to, how do I have that connection? Because maybe what I value is the relationship with my son as opposed to the physical activity of playing the football. So kind of thinking a little bit outside the box with that actually the values or the grief that we were feeling sad about, that it's important to acknowledge that we might try and adapt in a way for that. The self-care piece, I suppose, all the different aspects of our lives. And in some ways, there is a piece that we can do there in terms of acknowledging, actually, I have a need for self-care, and how do I manage that differently or better within myself? And how do I review it? You know, a monthly or a 6-monthly or an annual review, put a reminder in your calendar or your phone to check in with yourself, because we're often kind of, you know, future focused, thinking about lots of other things. In terms of mindfulness is something that I personally find very useful, and I think it's something that's very, very helpful in terms of cardiology generally. And there's a huge amount of resources online, but essentially it just means, people are like, oh, it's kind of a bit of a buzzword. It essentially just means paying attention in the present moment to one thing so that you can slow it down. And if you practice that regularly, you actually have much more of an ability to connect in with yourself and to be aware in the present moment. So there's lots of different resources there, so that might be available on the website maybe afterwards. That's it. Okay, great, thank you.
Hi. I'm definitely a little bit in fight-flight and have been doing a little bit of breath work. A lot of that is resonating with me. I'm very honoured to have the privilege to speak to you, and I'm just telling you about my experience, and I understand that everybody's is different and individual and unique. And I suppose I'm here to hopefully offer some hope to those of you that there is the potential for recovery to a better place. It might not be full recovery, but recovery to a better place. Can you hear me? That one isn't on? No? Sorry. Is that better? Can you hear me? Okay, so before January 2020, some of you might have heard this story, so I apologise if you're hearing it for another time. I was very well, physically active, walked and cycled everywhere, went to the gym, did my spinning classes, had a very strong yoga practice on my mat 3 to 4 times a week, normal BMI, normal cholesterol, normal blood pressure, not ticking any of the, or some of the boxes that are considered that high risk for me anyway. So it was a real bolt of lightning when I was woken out of my sleep with a thumbprint-sized pain on my left shoulder blade, which I initially thought was gastritis, but it got worse and worse and worse, and I eventually had that realisation that I was having a heart attack and I needed to call an ambulance, and my husband was running around frantically, and it was very frightening. So I was blue lighted straight for emergency stenting, and unfortunately I had an unusual complication where an artery was perforated. So I was on the table for 5 hours while the team were fighting to control bleeding, and I had another heart attack on the table. I surprised everybody by surviving, but I was left with a very large scar on my heart, which will never recover. And a couple of days later, I had a cardiac MRI, which was bleak, so I was transferred to be assessed for a heart transplant, which thankfully I didn't need. But I was given that diagnosis of heart failure. My ejection fraction was 15%, so I was told I was at risk of sudden adult death, so I needed to have an ICD, an internal defibrillator, put in. And I found myself 2.5 weeks later on my couch, totally traumatized, totally terrified, completely overwhelmed by the challenges that this condition brought me. I couldn't walk from here to there. I was exhausted and so short of breath from dressing, undressing. A shower was a feat for the day. I was filled with fear of dying every day. I felt like a burden on my family. I have worked as a healthcare professional all my life, and I was suddenly on the other side of a fence, the fence, needing care. Trapped in my home, trapped in my body. I was told to go home and live like a 95-year-old, and no offence to any 95-year-olds, but I couldn't do any more than that anyway. And I was told I would never climb another mountain, which was a very big deal for me. So 3 years on, I still have to plan my days. I still have to manage my condition every day, balance rest, activity, diet. But I am back on my bike. I am back on my yoga mat, and I've got up a couple of hills with lots of tears every time I get there, whatever that's about. So no one knows what you can achieve with time, medication, and hard work. I just have some suggestions of things. Some of them might resonate with some of you that I found helpful along the way. So learning about your condition, educating yourself so you understand the rationale for needing medication, for needing to make those lifestyle changes. Engaging with your caregivers, it's a two-way partnership. Like you was saying, don't be afraid to be honest, ask questions. You're the other half of this relationship, and your caregivers can only give you the best individualized care if they know where you are and how you're responding or how you're feeling and how treatment is going for you, whatever. So it's important to have those conversations. Have patience. Recovery is achingly slow. I would ring the nurses on the helpline in the IHF regularly, and it would often be, it's only 6 weeks, it's only 6 months, it's only a year, and I'm finding it intolerable to be stuck on my couch, not able to live the life that I want to live. So it took 2 years for medication to be titrated to the stage that worked for my body, and 2 years before I could start to escape my home independently again, which was very important to me. Exercise, go to your cardiac rehab. You need that individual assessment. You need to exercise with the monitors on your body so you learn that what's safe, and it gives you confidence to know what to do and to know what you can do. And sometimes that takes time. It was COVID hit when I was diagnosed, so it was 7 months before I got to cardiac rehab. But in retrospect, I wouldn't have been able for it before then anyway. I wouldn't have got the benefits. And it's hard to believe when you're so tired that you need to pull yourself off a couch to exercise. That's going to make you more tired. It's like, well, how's that going to work? But actually, it builds strength in your muscles. It builds those energy-making cells in your muscles. It actually does give you more energy, but it might take a long time for that to happen. And you're not going to be bursting with endorphins or all those feel-good hormones either. But I suppose it's really important to know that that exercise that you do, and that can be 10 minutes in a chair, and that's how I started, it's benefiting your body, and it's moving you towards having a better quality of life. So to stick with it and keep working at it. You're going to be tired at the end of your day anyway, so if you can look back on it and say, well, I did my rehab today, so that's a good day. For me, it was, one step forward, two step back. I kept making the same mistakes over and over again, ringing the girls, why can I not move for 3 days? Well, what have you done for the last week? And I'm kind of going, okay, you know, and keep hitting that wall, hitting that wall, hitting that wall. Didn't learn, kept pushing. But some of that pushing was possibly, you know, so you have to explore your own limitations, feel your own body, and that's going to change with time. And like that, as I say, it's you know, I was driven to the top of the pier and could walk from here to there and had to sit down and then walk back again. I'm now doing that walk from my home. So, you know, there is hope for building that. I was brave and went back to my local low-cost gym, and I'm the mad person who's hopping from foot to foot in my ass and abs class to keep my heart rate up, because I know that that's what my body needs. So I'm sure people think, who is that woman? But that's what I'm doing. I've learned what I need to do for my body. So I'm not going to talk about diet, except for, and possibly my healthcare background did not help me in this. I overnight changed everything, and Orna might have different things to say about this, but I felt like I was eating cardboard, which made me even more miserable. I love my food, and, you know, there was 6 months of hell trying to work out things that, you know, could work for me dietary-wise. My husband lost weight, you know, it was all a disaster area. Everybody was telling him how well he looked, but he wasn't as happy. Mental health. The psychological fallout is enormous and completely overwhelming. It's initially crisis management, you know, in trauma, shock, disbelief, terror. The only thing that relieves fear of dying is living, is not dying, you know, and that takes a bit of time to start to trust, for me anyway. I was consumed with grieving my old life. I had a new identity, which I did not like. I was a different mother, a different wife, unable to work, and I got so caught up in trying and working so hard to survive and prolong my life that I was forgetting to live. So, you know, there's lots of psychological things that you have to work through. And it impacts your relationship, my relationship for me, with my husband, with my children, with my friends. It all happened during COVID as well, so I had my own isolation going on during that time. So really important to connect with supports, your family, your friends. You might find some people step towards you, some people step back. That's part of it. As I said, I found the nurse helpline brilliant. I was very privileged that I got to see a psychologist in the first hospital and also in the heart failure unit. I also availed of heart failure or the IHF's counselling, a bit of low-cost counselling. I clearly needed to talk a lot for 3 years. So, you know, that whole psychological part of what happens to you is certainly for me, and maybe, you know, everybody's different, but for me it was huge, and I'm still working on that. That's still a work in progress. Find gratitude, which is really difficult when you don't feel very grateful for what has happened to you. So that's another thing to learn. But I suppose trying to focus on where you've got to, your achievements, and that achievement, as I say, might have been doing that 10 minutes rehab that day. Finding things that you're grateful for. For me, I'm very lucky to have a garden, sitting in nature, being driven to sit beside the sea. There's lots of free online courses, the mindfulness courses, stress control, living well with a chronic health condition is really good for learning about goal setting, action planning, making positive change. So you have to engage with things that you might find helpful. It's work, it's a work in progress. But there's a lot out there that you can get help from. Finding joy. Dancing in your kitchen, stone cold sober at 10 a.m, and that might be in a chair. So you just have to find moments of joy. For me, sitting around the table with my family is my favourite thing to do. And I have a beautiful new grandson who brings sunshine into my life every time I see him. So that's been a massive, wonderful thing that's happened for me. Finding your flow. This is terminology that I learned on one of the courses. But it's about finding something that absorbs you. It absorbs your attention. And when you have heart failure, it needs to be when you're at rest. If you're used to being very active, it's intolerable having to sit. It's like, are you kidding me? I have to sit every day and do so much sitting and resting. I've always been a crafter, thankfully, so I've knit, I learnt crochet, I'm trying to learn Portuguese on Duolingo. It could be chess, crosswords, art, creative writing. It doesn't matter what it is, but find something that takes your attention and just gets you through that time. So that's it, I think. My reason for standing here today is if I had met this version of me 3 years ago, it would have given me hope. It would have reassured me that there's somewhere to go and, you can have an improved quality of life. I have to mention the carers in the room, and that's the personal carers, the ones who are looking after those people with heart failure, and the healthcare professionals. Please, please, please prioritise looking after yourself, minding yourself. Your own self-care is really, really vital so that you stay well. That's it. Thank you.
Now, hello. I just think Karen's speaking there has been, I have no doubt, I can feel it from her desire to give people hope and possibility. And that is a gift that can't be prescribed. It can't be, thought through. It's one that comes from the heart. So, Karen, from your heart that has a compromised ejection fraction, we thank you very much for giving everybody that. It's very nice. So I'm here to talk about using the patient voice and a little bit of disclosure. I'm also a heart failure patient. I'm a heart failure patient for 11 years. So the first thing I'd like everybody to think is that, I'm standing here and that years are possible, because I know when the diagnosis comes first, apart from the shock factor, the next thing in your head is probably going to be, how long am I going to live with this? And I was 38 when I was diagnosed. It was a complicated journey. I had a torn artery in my heart, which was a sudden issue, but it was misdiagnosed for about a week. And I had 3 heart attacks, and I ended up having a cardiac arrest and eventually needing open heart surgery. But the problem was that even though, as I say, the pipework was fixed and my artery was replaced, the pump had been damaged so much by oxygen deprivation that I was told, literally, when I came to, that I had the heart of a 70-year-old. And at the time, I also had an 11-day-old baby at home because my artery tore after the birth of my 3rd child. So trying to process that my heart was, the immediate thought I had was, of course, am I going to see her grow up? Am I going to see my 2 boys grow up? And I applaud what Emer said earlier about asking questions. But I would say, and I don't know if many of you in the room have experienced this, while you might want to ask the question, sometimes the fear is greater than the seeking the answer. So you can end up living with a lot of fear that might otherwise be reassured. Like, I'm delighted to see and hear tonight about all the improvements in medication, improvements in therapies, in devices. For me, hearing about heart failure was just a sense of a death sentence, and I presumed I might have about a week, maybe 2 weeks to live. I had no idea, but I was afraid to ask too, because I thought, you know, what if they confirm that? What do I do with that? Ignorance was kind of bliss. Even though it wasn't bliss, it was torturous, because I was, of course, answering things in my own mind. So, you know, and the loneliness of that journey, the isolation, the not knowing anybody else in the same boat to relate to, because no matter how much our family love us and care for us and know, they're not in it. And so there are limitations as to what levels of support you can have. So again, thanks to Sinead on the psychological supports, because literally everything you put on your list, from PTSD right the way through, I ticked every single box. And I spent about 3 years trying to deal with that on my own, telling no one, you know, and not wanting to upset my family even more by telling them the thoughts I was having. So we desperately need, I think, when we're diagnosed with heart failure, to have an automatic right to speak to a therapist, where we can let out all that fear and upset and misery and even guilt, I would say, because I felt very guilty that I was putting my family through all this. So, so what has all that got to do with using the patient voice? In search, as I was, for the connection and the reassurance, the support, the finding people like me, when I was diagnosed, I just didn't find anybody really that I could relate to around me. And I was very frustrated with this, because I kept thinking there must be someone else in Ireland, you know, and that's how it was for me, because I thought, well, heart failure, you know, it must be very older people that have it, or, you know, I just didn't know, and I couldn't find them. I couldn't find heart failure patients anywhere. And I got very frustrated one day with my cardiologist, and I said, you know, it's bad enough having this and living with it and everything that goes with it, but to not know anyone and to not have any support, it's like I've accepted I'm in this little rubber dinghy out in the Atlantic, but could I just at least see another rubber dinghy somewhere, or even a ship would be delightful. And he said to me, you know, I'm going to write to somebody, he said, that I think might be able to help you. Now, at that point, I didn't know who it was, but it actually was somebody he knew in the Irish Heart Foundation. And I got a phone call about a week later from somebody there who said, listen, we've heard you've had this, that, and the other, and we're keen to learn what can we do to help you. And, you know, that phone call was the first sign of the dinghy, really, and it was the first sign of help. It was the lifeguard, I suppose I would say. And that process really opened so many doors for me thereafter. I got to know the other people in the dinghies, you know, a great number of heart failure patients of all ages, you know, all ages and stages, who have become genuine friends of mine. But I also, you know, apart from that kind of connection and education side, because eventually I got brave enough to start opening the booklets that they would send me and read a little bit about the condition, just enough so I didn't have to hear or read something I didn't want to take in. But the other side that it opened up for me was actually starting to, I suppose, address the issues that we were facing beyond the medical in our lives. I mean, our lives are turned upside down with the diagnosis of heart failure, there's no question, because it's not just going to affect your medical condition. As Karen said, it affects your relationships, it affects your ability to work. I had to give up my business. You know, I was trying to be a mom to 3 kids, and I, like Karen, was exhausted. Getting up, getting them out the door to school felt like a full day's work. But there was nothing really to help through that process. Who pays the mortgage, you know, when you can't work anymore? All of that. So the Irish Heart Foundation have an advocacy department that I was introduced to. And really over time, I started bringing up these issues, some of which they were very aware of. And they showed me, I mean, I would no qualms in saying I was a bit of a 1916 revolutionary, I think is the best way of describing me. I kind of wanted to go in guns a-blazing and change the system and have supports. And they were more the parliamentarians showing me the processes and the way. But I volunteered for 5 years, working away in the background, just trying to bring awareness to heart failure issues, but also trying to suggest ways in which changes could be made in Ireland to improve the situation for heart failure patients. And about 12 months ago, a position came up in their advocacy department, and I thought, well, you know what, I've been doing a lot of this as a volunteer, so I might as well apply. And lo and behold, I got the job of being the advocacy campaign manager to work on all types of advocacy, but particularly close to my heart, of course, is patient advocacy issues for heart and stroke patients. So what are the issues? What am I talking about? And advocacy sometimes can be such a big word, and people go, I'm not really sure what that is. So it really is about using the patient voice. I try to use my experience and my voice to give examples of the real life situation of patients. But every patient, as Karen said, has a unique perspective. And I won't have been through your situations. So one of the things we're really keen to do now, in addition to the national advocacy plans we have, we're trying to get a cardiac plan. We're trying to get the government to actually launch a plan for cardiac care. You know, we're trying to, I suppose, bring the awareness up, look at the area from the perspective of it being an invisible disability. People don't often think of heart failure as a disability, but it very much is if you can't physically do something. But in addition to that, we're hoping to take a lot of our patients who come into our service and those outside of it to help give them training and skills in how to use their own voice. And that could be to advocate at local level, might be to your local TD to say, you know what, we have no cardiac psychologist in our area. The amount of heart patients that need to speak to somebody and there's no service, we want to be there to help you do that kind of work in your community, or maybe be on a decision-making body in your community where you can put that voice forward. So we've just launched what we call our Patient Champions program, and it's not about being, you know, a champion that you've like done an Olympic feat with your illness and you're suddenly all better. This is about championing the causes and the issues that you deal with every single day. Like Karen outlined, from when we get up in the morning, you know, there's a process you have to get through to live in the real world. And if you've been economically affected by your illness, if your relationship has broken down as a result of it, or your family, you know, you feel you're being a burden to them and you're feeling guilty, there's a lot of stuff that goes with it. If there are areas where services can be improved to improve your lot and the lot of other heart failure patients in your community, we want to try and help as an organisation, not only to give you the tools how to do that at local level, but also to support you with an ongoing support network of other champions that, you know, you might discover are only 3 miles that way and 5 miles the other way, but it's a way of people being connected and feeling supported. We're also hoping that this initiative will help you learn about what we do as a national organisation and how you can support the endeavours we're trying to get over the line. Because sometimes there's a huge disconnect between what the likes of an organisation is doing from an advocacy perspective and what patients on the ground are aware of. So I'm hoping to see in time, and I know if you're newly diagnosed, you know, this is for down the line when you feel stronger, more able to maybe learn the skills or want to learn the skills about using your own voice. But your own voice is very important. You know, 11 years ago, it was around this time of year, I was in a high dependency unit, and I remember I couldn't even butter toast because a knife was the heaviest thing in the world. I was so weak. And I remember thinking, my God, you know, what good am I going to be in life now? You know, what can I do? How can I do anything? But it's amazing over time the opportunities that can come out of your illness and the opportunities to do some really good things. And I wouldn't be standing here today without a lot of people helping give me those opportunities. You know, and I'd like people here to feel the same. You might feel very alone and small in the arena of heart failure, but your voice could do such an amount of work to the power of 100, you know. It could be for other patients. It just could be amongst, you know, your community and building awareness, whatever it happens to be. So don't doubt your worth just because you have this diagnosis. Don't doubt your capability. And I would say just know that the advocacy department and this patient support department, we're all here for you to try and help make the journey better as the years go by for you. Okay? So I leave it at that for now. Thank you.
We have all the microphones now. Hopefully you can hear me okay. My name is Orna and I'm the dietitian with the Irish Heart Foundation. So I'm really happy to be here this evening to talk all things food and heart insufficiency. I love that. I'm going to keep that term going. So sorry I have the wrong wording up here. Food and heart failure, a lot of fear, a lot of confusion comes up. So what I'd love for you to walk away from this presentation thinking is that you feel a bit more in control of the food side of things, because we do it multiple times every day. We're eating. It's a huge part of our life. So it really affects our quality of life. And I want to start off by saying that changing the way you eat, especially if you've been eating a particular way for many, many years, it can be really, really difficult. So I just want to start out by acknowledging that and just remind you, you can take it at your own pace. So you can implement changes slowly, gradually, especially when it comes to salt reduction. Even small reductions matter. So just take it at your own pace. It's hard, but it does get easier. So how do your food choices, what you put into your body every day, how does that affect your heart insufficiency? Well, there's the obvious things. So I'm a picture person, by the way, so there won't be, I don't think, any text on these. So when it comes to your symptoms, often we've heard about lots more symptoms than breathlessness and swelling tonight, but salt in particular can really help minimizing those, fluid overload and feeling breathless, short of breath, the extra swelling on your lower limbs or wherever that might be in your body. but also certain dietary patterns can really reduce your risk of hospital admission, and then when you're in hospital, it can reduce the length of your hospital stay as well. And okay, you may not be feeling like this little stick man here all the time, but you know, fueling your body with the right type of food, nourishing your body every day, and keeping your kind of salt and fluid balance in check goes a massive way to helping to keep some of that energy, keeping that quality of life. And of course, from a long-term perspective, you know, looking at your other modifiable risk factors, so your high blood pressure, high cholesterol, your risk of type 2 diabetes, your weight, all of these things are affected by the foods you eat. So food has a huge, huge role, and there's a huge capacity to improve your quality of life through this. So do you think you need to follow a special diet for heart health? We get this question quite a lot, and the quick answer is actually no. So we've all seen the food pyramid before, whether it's the food pyramid or the Mediterranean style diet, or else maybe the DASH diet. So that DASH stands for Dietary Approaches to Stop Hypertension. It's the DASH diet. Whatever type of heart healthy pattern this is, it's the same for the general population as well. So we're looking to, they all have the same building blocks in it. We're looking to minimize the amount of salt, sugar, saturated fat in our diets, and maximize and promote the foods that are going to nourish us. So lots of fruit and veg, whole grains, low-fat dairy, a wide variety of different protein foods, and some heart-healthy fats and oils. And just keeping it very simple and straightforward, kind of big picture level, if you're either buying your groceries or else you're preparing a meal for yourself, if you look down and at the proportion on your plate, is half of the plate fruit, vegetables, or salad? Is a quarter of it your starchy carbohydrate foods, high fiber if you can, and is a quarter some kind of protein? It doesn't have to be fancy. It could be a slice of toast with some hummus, with some cucumber or a tomato on top. Simple, quick, doesn't have to be Insta ready or whatever. I feel like healthy eating has kind of become monopolized by influencers nowadays, but actually on a very basic level, if you're getting these building blocks in place, you're well on your way. So let's start with the big question, how to take control of salt. So we'll start with the word salt, I guess. Salt is sodium and chloride together, okay, two different minerals, and the sodium is the part of it that is the one that's kind of active in our body that causes us to hold on to more fluid. So it doesn't really matter what type of salt it is, whether it's sea salt, pink Himalayan rock salt, iodized salt, kosher salt, table salt, it's all the same. It's sodium and chloride, and that is how your body will see it. And in terms of what happens in your body, so when we eat more salt acts like a sponge, so it makes us hold on to more fluid in our body. It makes your heart have to pump harder, a little bit, work harder to pump the blood around your body. So it puts it under pressure. And for that reason, it can worsen your symptoms because that fluid can kind of squeeze out outside of the blood vessels. That's what causes the swelling, the shortness of breath, and also the other symptoms that Emer mentioned earlier, even gut symptoms, nausea, feeling full before you should be. All of those are related. And as well as that, it increases your blood pressure, and it also can damage the lining of your blood vessels. So if you imagine a garden hose and turning up the water, the tap, right to the highest level, and you have high pressure water going through that hose, you're more likely to damage the inside lining of the hose. And that makes, if you think of blood vessels, that makes it easier for cholesterol to build up when those blood vessel linings have been damaged. So all these things kind of work together. So how much salt should we have? So the World Health Organization says 5 grams of salt per day maximum. Our national guidelines from the Food Safety Authority of Ireland say 6 grams for the population. So the reason they've set it at 6 is because for a population, it's very difficult to get it down to 5. So really, if you're living with heart failure, you need to be aiming for the 5 gram mark maximum. What that looks like is, so 6 grams is only 1 level teaspoon, so not a heaped teaspoon, so it's not a lot at all. And most of us actually eat up to 10 grams a day. I'm sure the salt intake in this room is far lower than the national average. But the interesting thing about our salt intake is that only 10% of the salt that we eat tends to be the salt we add into foods. So 75% of the salt we eat is already in the food through processing it, and 15% occurs naturally in foods that just contain a small amount of sodium. So what are the big sources then? I'm going to hand over to you and shout out a couple of common hidden sources of salt to me. I'm curious. Crisps, yes. Bread, yes. Gravy, cereal. Soups, absolutely. So some really interesting suggestions there. Bread is often not recognised as, a very salty option, but actually up to half of the national salt intake, so this is from the Food Safety Authority of Ireland, half of our national salt intake comes from 2 particular groups, typically processed meat and fish, so things like sausages, hams, salamis, and also bread, which is not something that we would assume. It's part of the fermentation process. Also other sources, as you correctly said, salty sauces, so things like ketchup, soy sauce, mustard, even things like pickles or pre-made pasta sauces. Ready meals, someone mentioned crisps, so salty, savoury snacks, popcorn, pretzels, soups, packet soups, tin soups, and gravy, granules, or stock cubes. So, but if you look at these pictures, you'll see a lot of them have one major thing in common, in that a lot of them are processed or ultra-processed foods. So that gives us a clue as to what we can do to reduce the salt intake in our diets, and hopefully have it not taste like cardboard. So I'll do my best. The first is very, very simple, but it's true. If you're cutting out, eating out or eating on the go, and those ultra-processed foods, you're automatically going to cut out a lot of salt, because 75% of the salt we eat is already in these foods. So cooking from scratch at home as often as you can within your lifestyle, when you can, is a great place to start. When you're choosing, meat, fish, etc., can you choose, instead of fish fingers that are breaded, battered, can you choose plain bit of cod or darn of salmon or chicken breast? So just trying to go for the unprocessed where you can, and automatically cut out the salt that's added in the processing of those foods. And add flavour. This is vital. And I know it's easy to just say, oh, of course, season your foods. That's common sense. But, really taking the time to explore the vast opportunities in your spice presses, in your, the herbs that you can put into food. So there's, extra onion, extra garlic, root ginger, even vinegars, searing something in a hot pan with vinegar to oomph that flavour up, rather than boiling something, which is going to just sap out the flavour anyway. Herbs, everything from dill, basil, parsley, what have you. Do what works for you, but get creative, use as much as you can. Even the zest of limes or the juice of lemons, and also spices. So, even garlic powder and onion powder. If you don't have garlic and onions on hand, they're great tools you can use, quick, easy in the store cupboard. Just be careful that they're not the onion salt or garlic salt. And any spices that you like, just pile on the flavour, particularly in the first few months of you trying to reduce down your salt intake. Be sauce savvy, so when you're buying sauces, you know, if you can, make your pasta sauces, curry sauces, etc. from scratch. But if you're on the run, there's options that you can choose, you know, your reduced salt soy sauce, your no salt stock cubes, no salt gravy granules. There's a lot of options out there, so it's taking the time to find options that work for you. And this might seem like a really obvious one, don't add salt, but you know, we're in a habit of adding them to certain things, like when we're boiling potatoes, pasta, vegetables, just salt the water. Little things like that. Keeping the salt cellar out of sight if you can. And also even things like tinned beans, tinned lentils, you can get, a lot of them come with in a kind of a salty water. If you just pop them into a sieve, rinse and drain them and rinse them, you'll reduce the salt content by 40%. So little changes that you can make in this process really make a huge difference. And the last, as I think everyone has said here tonight, patience. You just need the patience of a saint sometimes, particularly for adapting to salt, reducing your salt intake, because the Irish diet, we have been conditioned to a higher salt level. So when you take that away, you really, really notice it, and I'm not going to lie. But this is an interesting fact. You grow your new taste buds on your tongue every 2 weeks, and with that new taste bud is the potential to re-educate your palate to get used to a lower level of salt naturally. So I'm not saying it'll take you just 2 weeks. It can take up to 3 months, and it is difficult sometimes, but really amp up the flavour during that time and stick with it. Don't panic, it will happen. Your taste buds will adapt. And then I absolutely have to mention this. This is fundamental to learning to take control of salt, learning to read food labels. So we have the Irish Heart Foundation food shopping card, which is available to order. You can get them free from us. But what you're looking at, if you're looking at, this is the back of a packet of crisps. You're looking for, per 100 grams, you're looking for the salt content. And you'll see it here, it's 1.5 grams per 100 grams. We don't want to have anything that's over 1.5 grams of salt per 100 grams. That's going to be a big source of salt. So if you're picking mainly products with, often you'll see they're color-coded anyway, try to pick more. If you're picking more orange or amber and green options, you're probably already doing pretty well when it comes to your the food choices. So take some time the next time you're in the supermarket. Bring your glasses, but sometimes you need a magnifying glass, to be honest, and you might look a bit crazy, just looking at them for, reading for that long. Another couple of clues that you can follow are looking at the ingredients list. So you're looking for words like salt or sodium or soda in the ingredients list. That'll give you a hint that there's and particularly if they're towards the start of the list, that they're higher in salt. And also look at the serving size of what you're having. So here I know it's a small serving size, but sometimes when I have, a pot of soup that I bought in a shop, I eat the full thing and it says it's 2 portions and, I have the full thing. So make sure that you're looking at the per 100 grams or per 100 mils, but you're also taking into account what your portion size is, because you could be eating double the amount of salt at that particular time. And then salt is really just one part. Like, it's a very important part of the food conversation when it comes to heart dysfunction. But when we look at the big picture in terms of our overall diet, fruit, vegetable, salad, only 1 in 3 of us in Ireland is eating even the minimum of 5 a day. So we could all stand to increase more fruit and vegetables, particularly fresh and frozen ones. Canned ones can have extra sodium in them or extra salt, so just watch out for that. Your whole grain foods, so your breads, pasta, rice, cereals, try to choose high fibre when you can. And also, if you're somebody who from this shelf typically mainly eats bread, maybe look at diversifying that and getting some variety and maybe more potatoes or pasta or rice, because bread is quite high in salt. So trying to get a nice bit of variety and high fibre. And also choose plain rice, plain pasta. You can add in your flavours to that afterwards. Milk, yogurt and cheese, so really important for our calcium levels and also for blood pressure control. Milk and yogurt, super, try to choose low fat. Cheese, just be mindful of cheese is always going to have a higher salt content, particularly hard cheeses. So try to keep it to maybe a matchbox size cheese a couple of times a week, but see what works in your lifestyle as well. And then from the protein shelf, so meat, fish, eggs, tofu, beans, lentils, all of these foods, nuts. Try to choose unprocessed where you can. And also, if you're living with if you've experienced any kind of heart dysfunction in the past, it's a good idea to include oily fish twice a week. And then fats, spreads and oil, so small amounts, try to go for the heart healthier options, so olive oil, rapeseed oil, any kind of non-tropical plant-based oils are best. And as we've kind of touched on earlier, trying to limit the foods that are high in salt and sugar and fat. And then lastly, it's really important to, how you eat rather than just what you eat. I think, just taking the time to sit at a table and make your mealtime sacred and not be kind of distracted by lots of things gives you the time to check in with your body and savor your food and the joy, the pleasure of eating, and actually will make the flavors stronger. So again, if you're trying to build up that flavor when you're reducing down salt, it's a really good way to eat more mindfully. You can smush spaghetti into your head if you like for a more sensuous experience, but it's up to you. But just, making sure you're getting in touch with your body, listening to your hunger and satiety cues. The only time I would say to just be mindful of your, hunger and satiety cues is if you're somebody who's struggling with a lack of an appetite, a poor appetite, maybe you're experiencing that nausea, that can happen for many people. So a couple of tips. First of all, if you're losing weight, and I mean your dry body weight, your muscle and fat mass, not fluid loss, this it will affect your muscle mass. It'll affect your ability to fight off infections, your energy levels. So really, really important to, if you're concerned that you're losing real weight, let your heart failure team know. Don't worry in silence about it. Say it so you can get a referral to a dietitian. And forget the idea of 3 meals in a day. Go for 10 tiny meals, little and often throughout the day. It's much easier when you have no appetite. Try to include protein at most of your meals, so some kind of a protein food to keep your muscle mass up. And try to include, a dessert maybe after your lunch or your evening meal, or both. The priority, if you're losing weight, is to maintain that weight. That comes first. And then just very lastly, a couple of resources. So I'm on Instagram at heart_dietitian. If you'd like to follow, I offer lots of heart advice tips. And I'm sure many of you are aware of a lot of the resources that we offer as part of the Irish Heart Foundation. We have lots of booklets available. So please do just let us know if there's any in particular that you'd like to hear about more. We have lots of recipes on our website. And thank you so much for your time.
Okay, everyone, I hope you enjoyed all those talks. We're just going to have a short question and answer session just for about 10 minutes or so. So our panelist speakers are just going to come up and sit here. We've a microphone. Katie has the microphone up there. So if you want to ask a question, just raise your hand and Katie will find you. Also to say, we're going to have teas and coffees outside afterwards, so if you want to stick around, we'd love to have a chat. So anyway, any questions?
I just have a question for, I can't think the girl's name, the advocacy girl. How are you? How are you? No, the one thing that perturbs me most, particularly with the state, is people with heart failure, they get very little help from the state, whether it's a medical card. I've suffered with heart failure for a number of years. I've had to give up work. I'm now an old age pensioner, but still don't even have a free GP card because the income level is so low if you're under 70. My wife has a big fat part-time HSE nurse pension, so you can imagine the amount of money, and we're not entitled to anything. It puts people off going to their GP. I know you can contact the heart failure unit, but is the Irish Heart Foundation doing anything to put any pressure on the government? Because it seems to be a very, very forgotten area. When you think of people with diabetes, they get it. Epileptics get it. They're hidden disabilities too. And yet people with heart conditions get absolutely nothing. So I don't know if this organisation can put any pressure on the government for this. The Minister for Health, what's his name, Donnelly, isn't it? Yeah. So that's all. I'm just wondering, are they doing anything about it?
Well, I've lived your life, as in I have experienced this firsthand. I mentioned during the talk that after my diagnosis, I had to give up my business. My husband was technically over a level, so I couldn't get a medical card. My medications at the time when I left hospital first were €90 a month.
They were 130 or 140, so it's gone down a good bit since that.
Yeah. And I would argue actually that what isn't even factored in is not just the loss of income, but the increased outgoings because you have a medical condition. So this is a topic that's very close to my heart, and one which my boss in the advocacy department is well aware of me championing this on a regular basis. And like I mentioned earlier, my instincts would be to just charge a building and make the change happen. But there are processes, and unfortunately, they require lots of homework done, lots of ducks in a row before you can kind of make the case. And this is what I've learned working in advocacy, I suppose. So yes, we know there's a problem. Yes, we know our patients have it. As I say, I've lived it, so I fully understand it. What we need now is metrics to back it up. We need numbers of patients going through it. We need to cost out what the cost of actually remedying the situation would be. And we need to present, I suppose, to government and ministers that are involved in those decisions, literally the package that says, right, it is costing you X, Y, or Z if people cannot have their medical care. But on the flip side, if you invest in the likes of giving them medical cards, etc., you're likely to have a better quality of life for the patients so that they can be well. And that's what we have to do. And a lot of the job, it's very unglamorous, I'll have you know, a lot of the job is literally trying to fact find. We have other issues as well that we face as an advocacy department because we don't have any national database of numbers of patients. So like Emer mentioned earlier, she has this estimate of 90,000 people with heart failure, which she doesn't like using. We have no national register. So that's another thing we're trying to campaign for, because it's very hard to explain the scale of need when you can't actually provide the numbers of people who are in the situation. So please know it is something we are definitely working on. And it's really trying to build a case. I often say, I don't know if you remember years ago, the detective Maclaughlin, or he was a lawyer, I think, and he used to be building up his case to get the criminals. And I'm not suggesting the government are criminals by any stretch of the imagination here. But what I'm saying is it's a case building exercise. So knowing there's an issue is one thing, but demonstrating that it's better to correct that issue from a, even, dare I say, a financial perspective. You hope, obviously, from a moral perspective and all the rest of it, that it's taken on board. But obviously, we all know that government has to function on numbers and spending and all that. So we are building the case. We are like Matlock every day. We're building up our case, and the patience of dealing with the diagnosis is similar in advocacy. It's the patience of waiting for that extra little bit of information that's going to build up your case further. So all I can say is bear with us and know that it's certainly on the agenda. Thank you. Is that okay?
Sorry, just want to ask you one thing on dietitian. We have all these what you call flags, what we're eating, high level, low level, sugar. What is to do with the chemicals? Practically all the chicken that we eat in the supermarkets, they say fresh and so forth, there's chemicals in them. Practically, I only heard last week in a fish shop, this lad looked for salmon, and your man behind the counter said, "Now, which salmon do you want? The farmed or, Donegal catch or something?" And that's not on any labels, is it? The chemicals, and are the chemicals dangerous?
So there's probably two
Oh,
elements.
sorry, thank you very much, sorry.
You're welcome. There's probably two elements to this conversation or answer. One is the European Food Safety Authority rigorously assesses new food products coming onto the market, and I will say that our levels of that manufacturers need to reach are extremely tight, certainly compared to the US. So that's, from in the European area, there is some safety there. In terms of whether, chemicals, let's say, are allowed into foods or not, it depends on, whether they're organic, non-organic. I know we have 70 million chickens in Ireland, and the vast majority of them are non-organic. So certain levels of different compounds are allowed in foods, but from a nutrition perspective, they're the same as there is no difference from a nutrition point of view, but we do know that there are some impacts of chemical compounds in foods on our microbiome, like our gut bacteria and other functions in our system. But it's a whole new area that really the science is only starting to explore. So really, really good question, but there's not really many answers to us yet in the meantime. But hopefully the EFSA, the European Food Safety Authority, the standards that need to be met within that kind of put your mind somewhat at ease.
Professor Joyce mentioned when she was talking about blood tests that we should ask what our BNP levels were. Now, I normally look close enough at my blood tests. I don't ever remember seeing BNP, so I'm just wondering, could you tell us a bit more about it? Thank you.
Can you answer that, Pauline?
Yeah, again, from the patient perspective, I can tell you, so it's something you have to ask for. Down my neck of the woods, I live in County Clare, most of the GPs or the doctors I have gone to there for blood work would say, "Oh, your BNP, why do you want your BNP?" It costs more money to do that, to run that test, right? They're not keen to do it. But if you say, "I'm a heart failure patient and I want to know what my BNP is," There's very little to argue with in that, because your BNP actually shows the enzymes that are relating to your heart. And you know the way in our bloods we get a scale, and there's the norm, and then there's sometimes us outside of it, or inside of it, we hope. But BNP is one of those where it will show what a regular heart, I suppose, would produce. But, you know, if you've had a heart event or if you have heart failure, your enzyme levels could be through the roof relative. So it's not to give you a fright if you look at your results. That's all, you know, they're conscious it's going to be very different to the normal range. But it's a question of asking, and again, using your voice, and I probably should have said that as well. Sometimes the using our voice isn't always to the political and the lobbying there, but it's using it in the medical setting, you know, and feeling entitled to say to your GP or your cardiologist or whoever, you know, I want this piece of information for my peace of mind, or my, you know, whatever the reason is, you're entitled to it, you know. So, okay.
Great. So, anyone else? Any?
Oh,
Yeah. Okay.
Hello, good evening. Just a general question for advocacy. I think a lot of people, when they go through cardiac arrest or a cardiac event, they ask the question, what is the roadmap? What should I expect? And I know we talked about a lot of the things in the range here this evening, but when people come out of hospital and you hear it all the time, they feel very vulnerable and frightened, and they kind of say, what should I expect? Like, is it going to be, if I broke my leg, someone would say, well, you should be up walking in 4 months. But I think when it comes to cardiac, it's kind of like, is it going to be 6 months? Is it going to be a year? Is it going to be 2 years? Is it, you know, how long will, and I think maybe for the Irish Heart Foundation, it would be good to have something to say, a typical roadmap would look something like this. And then people could kind of see what stage they're at, and then maybe inform themselves, say, well, I think I might ring them then and ask them about that. I'm 6 months into recovery and I still feel, but it gives them that kind of, as I say, a roadmap, yeah.
Yeah, I fully agree. Often what we find is when people are you know, they leave the hospital, the care might have been very good up to that point, and you go through the hospital doors, and often I've heard it described like falling off a cliff. I know in my case, it was sort of just figure it out, really, go home and figure it out. So 2 things on that. One of the things we're advocating for is we want a proper cardiac plan in the country. We're lacking it. The last one went out of date in 2019. But as part of that, we want to have proper discharge plans for patients. And a discharge plan would be, right, here's the next step. In your community, for example, there will be an occupational therapist will visit you to see if there's any aids you need in your home, etc., etc. So they would talk you through. And that's what we want. And, you know, again, the lived experience, and I'm sure Karen can speak about this as well. You know, the diagnosis and learning to manage it is hard enough. But sometimes what's really difficult to process, I think, is that there may be a service that you can't hear about and that you only hear about 3 years later, and you think, oh my God, that would have been great if I'd known. Or else there is no service, in which case, again, it's appalling because you're already going through so much. So definitely we're advocating for it. In terms of markers or kind of steering you towards a typical situation, I'd very much refer you to the patient supports. And by way of that, we have, now each patient obviously it depends, right? Depends on what level of ejection fraction, like Emer mentioned, you have. It depends your stage of life, your, you know, all of that. So it's not that anybody can give you a prescriptive notion about where you're going to be in 6 months, because, you know, even the doctors would fail to be able to kind of deliver that. But the patient support team are very good at being able to guide and steer you towards what they would call a journey, really, from when you might come on the phone to them right through to the supports they can give you all the way. And sometimes at 3 months or 6 months or 9 months, you might need a level of support that, you know, you wouldn't need a year and a half down the line. But they're very good at giving you kind of notional ideas on what is available and what you can have at what point. And also the nurse line that's available there is very good by way of getting some security and reassurance medically, because I suppose we're all afraid we're going to slip back, and we need to be able to talk to a medical person sometimes to say, look, is it normal? You know, if I feel a bit breathless here or there, is that kind of normal for this stage? And often the nurses are very good at reassuring on that front. So join the club is what I would say in terms of the patient supports. Join the club and you'll be much more maybe informed and reassured by all the different services they have to offer. Would that sound okay to you? Yeah, okay.
So there's another lady just over here, Katie.
I'm a vegetarian, and the cheese I'm eating, I do have it every day. And I was just wondering, am I having too much, or should I have what you just said about a matchbox size?
So,
I'm eating the vegetarian cheese every day, like I'm toasty.
so vegetarian.
So I was just wondering, am I eating too much?
Okay, so just in case people didn't hear, she's vegetarian, she's eating vegetarian cheese every day. She's wondering, is that too much? And can I just ask, is that a vegan cheese, or is that made from cow's milk? The cheese. The cheese, is it a vegetarian, or is it vegan cheese, or is it vegan cheese? Okay, yeah. So with all plant-based alternatives to dairy products, just be very mindful of what's in them, because it varies so much. You know, lots of dairy alternatives to yogurt and milk are fortified with, you know, calcium and iodine and different nutrients that we would have gotten in dairy, like cow's milk. Very much not the same for cheese. It may not be as good a source of protein as the dairy alternative, and it might have, you know, it might be more processed in terms of the different ingredients that are in it. So just have a look at the label, make sure it's a good source of protein, and is it offering you any of the nutrients that you'd often get from cheese? Is it fortified with calcium, etc.? From cheese overall, I'd try to keep it to maybe twice, max 3 times a week, and that portion size of a matchbox size of cheese. It depends on overall what you're eating. You know, if that's the, you know, the worst thing in your diet, you're flying it. But you know, there's always, everyone's different. So if you want to even talk with me one-to-one after this, I can chat it through a bit more with you.
Yeah, thank you.
But also, just lastly, as a vegetarian, really important to make sure you're getting your sources of calcium then if you're going vegan. Yeah.
Yeah, I'm on calcium anyway every day. Thank you.
Great.
Okay. So we're going to wrap up now. Just wondering if anyone else has any questions. Yes, this gentleman over here.
I mean, to the 2 ladies who have recovered remarkably, Pauline and Karen, in your journey, recovery journey, how did you guys, like, you know, for me, how did you realize, like, how much is too much, like, in any aspect, like, you know, walking, food, or anything, like, in recovery? How did you realize that, okay, I had a month back, I got a stunt. Last week, again, I got a stunt. I'm trying to get back to track, but I'm not realizing that fear kicks in, that, okay, should I walk 10 steps? Should I walk 20 steps? Should I walk 30 steps? Should I eat this much? Will that trigger again the symptoms? So how did you guys actually progress over your recoveries? Like, thank you.
Hi, thank you for the question. It's really feeling it, and as I said, I kept making mistakes with that. So the learning around how much you can do is day to day, and you're going to feel different day to day, and then as months go on and years go on, you know, hopefully you're going to be moving in a direction where you are able to do a little bit more. But sometimes with heart failure, it's complicated, because sometimes you'll know your body is letting you know this is not okay. and I can't even really explain what that feeling is, but you just know it's just not okay. Your heart or whatever is going on, it's not okay. I made the mistake thinking that I'm better than I am of running for a bus recently, and I felt very unwell after it. I can never run for a bus. That's not okay for me because I haven't warmed my body up. I can do really well when I've warmed my body up. And I suppose that's really important, is that before you do any kind of exercise, you need to warm up your body slowly to open up your coronary arteries, to give your heart extra oxygen and extra blood before you put that extra demand on it. So that's really important every time you do any kind of exercise. And unfortunately, you might do something one day and it goes well for you. You might push too hard, and the fallout with heart failure, and again you have to learn this over and over again, is you'll be exhausted for 2 or 3 days afterwards, and it's only when you look back. So you have to start keeping a record of what you do, or noticing what you do and noticing how you feel after it. And like that many, many times, I walked too far and I was floored for 2 or 3 days afterwards. So that's unfortunately a learning in living. That you just have to move through slowly and get the supports. I mean, I don't know whether you've done cardiac rehab or... That's really, really important because, again, you'll get the reassurance. You'll also be given a target heart range. So you'll start to learn, and they use what's called a Borg scale. So it's feeling in your body. So you need to be warming up, exercising at a level where you are actually exercising, so your heart rate is up, but you can, I can't whistle, I can't even remember whether it is whistle or sing, but anyway, you can say the first line of your address, but you should be able to hold some level of a conversation. If you're getting too breathless that you can't say that first line of your address, you're doing too much and you need to pull back. So you need to be in that mid-range, and that's really important. If you push too far and you're exercising in that higher range, it's anaerobic, it's without oxygen, it's not good for your body. It's not good for anybody, well people's body, never mind ours, but we have to just be really, really vigilant about minding your heart within that exercise. I don't know if that's helpful.
Okay.
Can I just ask, where do you get the rehab? Where should that start? Is it when you're in the hospital, or is it, because I've never had it, and I'm 6 years post an event like that, all that stuff has happened, the tiredness, but I don't know where to go for the cardiac rehab.
Well,
I can answer that. You need to go to your cardiologist or even your GP, and they'll refer you to the nearest cardiac rehab centre. Everyone is entitled to his heart failure to cardiac rehab once they're not stage 4. New York Heart Association class 4, and nobody here is that. So everyone's entitled. There will be a waiting list. That's unfortunate, but the sooner you get on the list, the quicker. But you are entitled to it. You fall into the category of eligibility if you have heart failure.
And just if you have heart failure, you're entitled to it?
Yes. There are waiting lists, so in all. And they're usually hospital-based. Yeah.
and just to add to that, where I started, there's the Irish Heart Foundation have a cardiac rehab online, 10 minutes. And they also have classes every day. And again, they've beginners, you can work that out. And I started with doing 10 minutes, and that's where I started from. And walking is an enormously beneficial free exercise. And again, you build that slowly like that. I'd walk from here to there, and then the next week I'd walk a little bit further for a little bit longer. And again, it's a really, really good way of building strength and exercising.
Can I just add something to sorry.
Sorry, I just might add one thing there, because I can almost feel it coming from you when you ask that question. Our physical capability and our psychological capability are in two different zones a lot of the time. And I think when I was diagnosed first, because I was wanting to be mom and wanting to do all these things, I tried a mind over matter approach. And I would overdo, and like Karen said, I would spend 3 days not being able to do anything, feeling like a failure. Like I was a bad enough physical failure. Now I was making life worse by not, managing it properly, as though there was people all around me very capable of doing it. So I think it's really, and I would always say this about the heart, it's a journey of the head as much as the heart, It's about understanding that famous quote, a journey of 1,000 miles begins with one step. And if you can make marginal increases and allow the days where you're not making any increase, in fact, allow the days where the walk you did yesterday today was tougher, it's about the expectation. Bring it right down to where it doesn't feel natural, where you feel it's almost minimal. But I think you'll have more success in the long run. If I was going back to me, back in the early days, that's what I would say. My expectations were crazy relative to my physical capability, but I was trying to prove that I could be normal, and I had to learn the hard way, and I had a lot of setbacks. So reduce the expectations. You'll still get there. Because look, I wasn't, this, I'm thinking back 11 years ago at this time, or even 9 years ago, or 8 years ago, I would be in my pajamas ready for bed. I would not be able to be functional. I certainly wouldn't be able to be talking to you at this stage, because speech would have been too much energy at this stage of the day for me. So you will get there. But just go easy on yourself psychologically in order to get there, okay?
Okay, so thanks everyone. Oh, there's one more, sorry.
No, sorry, it's
okay.
more an observation than anything. I feel a complete fraud because I landed in at my GP's behest to have an echo, because he had done the BNP thing. I'd never heard. I was literally going in saying, "Oh, what BNP?" All I could think of was the bank, and because of that, I needed stents and et cetera, et cetera, et cetera. And then I felt completely vulnerable, and this thing in my body, all of those things. And then had to wait 6 months to have the cardiac rehab thing, which was brilliant in Dún Laoghaire. And then at the end, where you have the thing when you do the series in hospital, and then you can go into the community one, where we all swap war stories and show off on cross trainers and things like that, which is brilliant. But then another bit, but because I have health insurance, some of it was paid for that I needed, some of it wasn't. And it's the waiting that I just think must be so awful, that you're going, well, I can do this, but I have to take 2 days to recover from doing it, on and on. But while you're still waiting for something which you are entitled to, but you've got to wait for it because the facilities aren't there, that's a huge problem. I mean, I think I've got sort of past it at this stage, but it's but the injustice, if you like, of it is the thing that I find annoying still. I'm also sorry. Can I just say I just go home and I'm going to measure out the 6 grams of salt and put it in the corner and say that's what you can use, because I do like my salt. Thank you.
Yeah, look, just to address that, we're aware people are not getting the services in a timely fashion. They're not getting, as was mentioned earlier, discharge plans to show them what's available in their community. And this is where advocacy, and this is why also we're bringing it right down to grassroots level, because we can try and push a national agenda, but we need, I suppose, more voices in the community as well that are shouting that. And yeah, it's as I said earlier, it's a huge weight to carry the diagnosis in the first place, but then to think that you're further laboured by not having the supports you need is the pits, And look, that's what we're trying to do. And if, we mightn't often be in advocacy be able to launch something, but know that we're actually really working in the background, trying to figure ways, avenues towards decision makers with the evidence that will just convince them. But it's difficult, and the political landscape is challenging. Some people have different priorities at different times, so there's a lot of variables at play. But all of these items are on the agenda. Just to let you know, genuinely, they are all on the agenda. And I'd love to say, you know, in a year, I'd love to have X, Y, and Z over the line, and in 3 years and 5 years. Mentally, I tell myself this on the days when it's tough to kind of, you know, push through or feel like you're set back with you know, some meeting that you've had where you're kind of trying to whip up the appetite for change. But look, please God, a bit like the heart failure itself, with the little steps every day, please God, we'll eventually get the 1,000 miles in, you know? Okay.
Is there any more questions? Because before we finish up, I just want to inform you about the Irish Heart Foundation support service for people living with heart failure. So, you know, just to let you know, there is supports out there. So you would have all seen, we've these leaflets scattered around. So if you pick one up, and we'll have the nurse line number. We actually have one of our nurses, Aileen, is outside. If you want to ask her any questions, she'll be able to provide you with some information. There is the Cardiac Rehab for All, actually. It's on the website, which, you know, if you're waiting for cardiac rehab, maybe check it out. There's a couple of other online supports, but we also have a support service where we can ring you and just see how you're getting on and guide you in terms of what support you'd like to avail of. And we also have counselling as well, and the Facebook group. So please take this home with you. We have our heart failure support packs as well. If you can try and grab one of those before you go. So thanks so much, everyone, for coming tonight. And again, thanks to all our speakers. I hope you found it as informative as I have. We will have tea and coffee outside, so if you want to grab a quick cuppa and meet each other and have a chat with any of the Irish Heart Foundation team, we're sticking around for another 20 minutes or so. Okay? So thanks, everyone.